Psychiatry, pathology, psychoactive drug intoxication and withdrawal. All right, so first and foremost, the way that I'm going to be doing this is I'm going to be telling you the drug. I'm going to talk about its mechanism of action, the intoxication effects, and then the withdrawal effects. The reason I struggled with this so much when I was actually studying is because I would confuse intoxication symptoms with withdrawal symptoms. I'm going to try to separate them as best as possible and give you just the highest yield thing that you need to know about each one, okay? And we're going to talk about that in the summary at the end, all right? I'm going to speak in full for each intoxication and withdrawal symptom because I think it's important that you know. And then at the end, I'm going to kind of run through it quickly to tell you what is like the highest yield thing to know, all right? So to begin, first and foremost, we have our depressants. Depressants are alcohol, barbiturates, benzos, opioids, and inhalants. So alcohol, barbs, and benzos. Let's first talk about these three, okay? And the reason I'm clumping them together is because they have the same mechanism of action. They're all GABA A receptor positive allosteric modulators. And what does that mean? Okay, so each alcohol, barbs, and benzos bind to a different site. They're not binding to the same site, but they bind to a different site on the same receptor, okay? And they cause an increase in flow of GABA into the cells. Okay, and so that's why these drugs are known as depressants, because GABA, as we know, is one of the primary inhibitory neurotransmitters in the central nervous system. Okay, and that's key to figuring out, what occurs during the intoxication and then what's to follow with withdrawal. Okay, so first, alcohol. Alcohol, once again, the MOA, mechanism of action. Whenever I say MOA, that's mechanism of action. The MOA is GABA A receptor positive allosteric modulator. All right, so it lets GABA in. So intoxication, you're going to see, slurred speech, ataxia, blackouts, because you are inhibiting your central nervous system, okay? Not too high yield, not something that you really need to know too much, okay? And one of the higher yield things, and it's associated with GI, which we'll talk about later, is that on your LFTs, your liver function testing, you're going to see AST 2 times the value of ALT. Okay, so if you see it, that is a common classic alcoholic picture. So if you have 200, it'll be around 212 for AST, and then they'll say 100 for ALT. That's a common classic alcoholic picture. Okay, now not too high yield for psych, but it's important to bring up during alcoholic intoxication. Now during times of withdrawal, right? As you continuously do this to your body, you constantly drink alcohol over years continuously. What happens is that those GABA receptors, all right, they're going to be constantly opened, and you're going to have constant inhibitory responses. And so then when you abruptly stopped with withdrawal, your brain's whoa, we have we had so much surge of GABA. So what we need to do is compensate. We need to stop release of GABA, okay? So the body's whoa. We had so much inhibition, let's stop GABA release. And so what happens is that it flips over. The seesaw tips the other way towards the activation of glutamate receptors, of NMDA glutamate receptors. So you'll see actually in alcohol withdrawal an increase in activity of NMDA glutamate receptors because you had so much inhibition, so they stop the release of GABA, and that tips it towards the excitatory glutamate neuroreceptor or neurotransmitter. All right, so you're going to see increased activity of NMDA glutamate receptors in alcohol withdrawal, and that's what causes your excitatory symptoms in withdrawal, which is going to be tremors, insomnia, you can't sleep, you're sweating, diaphoresis, agitation, you get withdrawal seizures, you start to seize, because remember, this is your excitatory neurotransmitter. This is glutamate, your NMDA receptors. You get hallucinations, okay? And then the scariest one of all is delirium tremens, okay? And delirium tremens is going to present 48 to 96 hours after the stopping of alcohol usage. And you're going to see autonomic hyperactivity, right? So autonomically, you're going to be hyperactive because, once again, what's happening is you have increased activity of NMDA glutamate receptors because you've utilized all that inhibitory response constantly, and you've taken advantage of it while drinking alcohol. And so your body has been whoa, we had too much inhibition. I want activation. We're not going to release any more GABA. Okay, and so then it tips over to the excitement, and it causes delirium tremens, which is autonomic hyperactivity. You get drenching sweats, and the way that this is going to present, once again, is the patient's most likely going to be in the hospital for one reason or another, and they're going to be fine on presentation, and then 3 to 5 days later, you're going to look at them and they're going to be sweating continuously. They're going to be agitated. They're going to have autonomic hyperactivity symptoms. They could be potentially having hallucinations. They could be altered, all right? And that tells you, they were normal on presentation and now they're altered 3 to 5 days later with all these hyperactive symptoms. It's most likely going to be alcohol withdrawal, okay? That's how they hide it. And they won't tell you that the patient's drinking alcohol, all right? Next is barbs. So barbs, same mechanism of action. dangerous to use with alcohol. Same with benzos, right? You don't want to use any of these together, right? Because then that doubles the GABA receptor modulator, right? So you'll have even more inhibitory response, and it could lead to severe marked respiratory depression. So that is one of the common things in intoxication for barbs, is that you're going to see a drop in respiratory depression, okay? Now, for withdrawal for barbs, it's going to be relatively similar. You can have life-threatening cardiovascular collapse, though, is key there. For benzos, what you need to know is in intoxication, so same mechanism of action. In intoxication, pretty similar. You could have ataxia, minor respiratory depression. And the treatment for benzo intoxication is going to be flumazenil. Flumazenil is going to be a benzo receptor antagonist, and it's something that they want you to know, okay? So patients that are benzo intoxicated, give them flumazenil. Now, you treat alcohol withdrawal symptoms with long-acting benzos, and that's very, very high yield for you to know, okay? Very high yield for you to know, all right? And it's the reason behind this is so that benzos pretty much have the same mechanism of action as alcohol, but if it's long-lasting and long-acting, you could kind of curb the increase in activity of NMDA glutamate receptors seen in withdrawal of alcohol by giving them a long-acting benzo, right? Because a long-acting benzo is going to act via GABA receptors in a positive fashion, and it's going to offset that severe increase in activity from NMDA glutamate receptors that we see in alcohol withdrawal, okay? So I hope this all makes sense. It's always like a seesaw. In our brain, it's a seesaw between excitatory versus inhibitory. That's the constant war that's going on. And we want to kind of make sure that seesaw reaches equilibrium, all right? We don't want it to be out of whack too much. Now for benzos, if you withdraw from benzos quickly, you can see seizures, anxiety, tremors, insomnia, and sympathetic hyperactivity, right? Very similar to alcohol withdrawal, because once again, it's going to be due to the fact that you have increased activity of NMDA glutamate receptors, which is excitatory, and it's going to cause this anxiety, tremors, insomnia, sympathetic hyperactivity. All right? Next is opioids. Opioids, we know that they act via the mu receptors, the opioid receptor modulators. But what they want you to know, and this is very high yield, is intoxication versus withdrawal symptoms, okay? So intoxication symptoms, you're going to see pupillary constriction. So whenever I see pupillary constriction, the number one thing in my mind, I start thinking about opioid intoxication. If they say pinpoint pupils, or their pupils are small, right? They'll say 1 millimeter. That's going to hint me towards opioid intoxication. Also, constipation, decrease in GI motility. You get respiratory and CNS depression. So you can see the respiratory rate potentially in the question stem might be like 8, okay? 10, 8, 6, something severely low. Then you know that it could be potentially an opioid intoxication. CNS depression as well is seen, so they could be passed out. And what they want you to know is for overdose treatment, you could give the patient naloxone. Naloxone is a miracle drug. It saved so many people's lives. And just kind of being out on the street, giving it to police officers so that they can help, any patient that is struggling with opioid intoxication or overdose in the streets. Now, overview on opioid intoxication, because it's so high yield. You're going to have depressed mental status, depressed respiratory status, constipation, and the key thing, meiosis, or pupillary constriction, okay? Now let's look at the opposite, the withdrawal from opioids. Withdrawal from opioids, you're going to see dilated pupils, okay? Diarrhea, right? This all makes sense. It's just going to be the opposite effects of intoxication. So dilated pupils and diarrhea. But some odd things that will really key you in to opioid withdrawal are going to be yawning, rhinorrhea, so whenever they have a runny nose, lacrimation, so tearing of the eyes, and piloerection, which is goosebumps. Those are very odd things in presentation that you normally don't see with any other pathology, and so that could help you really hone in on the opioid withdrawal symptom. And what you have to give the patient is methadone or buprenorphine, okay? Methadone or buprenorphine, which is our long-acting opioids, all right, in order to curb their withdrawal, all right? You don't want to give them naloxone because then you could further shoot them into further worsening withdrawal symptoms. And this is going to be seen, and we already discussed this probably in reproduction, but when a patient has abstinence syndrome, all right? So if a baby was delivered due to a mother using opioids throughout pregnancy, they could come out with withdrawal, right? So that's why you see yawning in that patient. And so with yawning in that patient, you don't want to give them naloxone because you could further worsen their withdrawal symptoms. You have to give them a long-acting opioid like methadone or buprenorphine, all right? So that kind of is a full picture of, it's a connection to a pathology that we already previously discussed. Lastly is inhalants. What you need to know about inhalants is that if you see a perinasal or perioral rash, that just rapidly onset, you know that it's a glue sniffer's rash, okay? And it has rapid recovery later on. So if a patient comes to you, they're acting weird, he's like, he's just being weird, okay? If they're being weird, that means that they're trying to hint to you that they have some type of like alcohol or some type of drug usage, and they're trying to hide it from their family, okay? So that's kind of one of the symptoms that they always present with. And if they have that and they also have like a perinasal or perioral rash, they're talking about glue sniffer's rash, okay? And that's an inhalant. Next is our stimulants. So we just finished with our depressions. Next is our stimulants. And what I want you to know for our stimulants is kind of the overall intoxication versus withdrawal picture. The one that I specifically care about is cocaine, but I want you to kind of know overall what stimulant, intoxication, and withdrawal looks like, and then we'll dive deeper into cocaine specifically. So overall intoxication of stimulants, you're going to see mydriasis, so dilations of the eyes. Okay, you're going to see dilation of the eyes, opposite to opioid that has pupillary constriction, miosis. So stimulants have intoxication, mydriasis, dilation of the eyes. They can present with tachycardia, hypertension, and diaphoresis. Makes sense, right? Because this is a stimulant. So majority of these drugs act by stimulating the system. It's going to be excitatory. Whereas on the other hand, the withdrawal symptoms are going to be, somewhat of like a crashing period, okay? They can have depression. They have lethargy. They have increase in appetite. You're going to see a lot of sleep disturbances, all right? Vivid nightmares. Those are very key to withdrawal from stimulants, okay? So you have amphetamines as a stimulant, you have caffeine, but the number one thing that I want to talk about is cocaine. So cocaine's effects, one of the main things you need to know for mechanism of action is that it blocks reuptake of norepinephrine by inhibiting the NET, norepinephrine transmitters or transporters, and that leaves more norepinephrine in the synapse, okay? And it also can block the reuptake of dopamine at the dopamine DATs, dopamine transporters, and serotonin. But specifically for cocaine, I think the highest yield thing for you to know is the norepinephrine transporters. All right? So it inhibits neurotransmitter reuptake. So let's see what the intoxication is going to look like. So when you're intoxicated with it, it's going to have pupillary dilation, which we already discussed, right? Which is common for all stimulants intoxications. You could see hallucinations. Sudden cardiac death is very, very common, like a very commonly tested question. It could cause, because cocaine can cause stroke and MI due to vasoconstriction. And so that's very key, okay? It can cause stroke and MI and sudden cardiac death. It has a lot of heart abnormalities and problems. So you could see potential chest pain involved with cocaine and toxicity. You can also have seizures involved with it. Now, chronic use may lead to perforated nasal septum. That's something that they might ask because it does cause vasoconstriction, as we already discussed. And the treatment is benzos. You have to give these patients that are intoxicated with cocaine benzos. Now, the one thing that you must avoid in these patients is beta blockers. Remember, beta blockers can cause a severe hypertensive crisis when given to cocaine users that are intoxicated with cocaine because of a severe vasoconstriction event. All right? So we want to avoid that. When it comes to withdrawal, what you need to know is that the patient's going to present with acute depression. They're going to be depressed. They can have vivid dreams. They'll be fatigued. They'll have hypersomnia and then hunger. Hunger is key to withdrawal from cocaine. All right? So those are that's the overall cocaine and what you need to know for intoxication versus withdrawal and the mechanism of action. And it's very similar to stimulants, but once again, they want you to know specifically cocaine. Then the last one is nicotine. Nicotine, once again, not as high yield, but they want you to know the therapy in which you could stop nicotine usage. So for smoking cessation, what they want you to do first is to assess barriers to quitting and set a quit date. Okay, that's the first thing they want you to do. And if they try very hard, and we've tried nicotine replacement therapy with like patches or gum, then you could try the drugs that are very helpful. One that they really want you to know that they quiz you on is varenicline or varenicline. I don't know how to pronounce it, but I think that's how you pronounce it. And bupropion, okay? And then lastly, we have the hallucinogens. This is going to be our LSD, our cannabis, ecstasy, which is MDMA, and then PCP, all right? I'm going to give you kind of the quick hitting things for each one of these. For a patient with LSD, the way that you know that they're intoxicated with LSD is that they're going to have visual hallucinations, visual and auditory hallucinations. Very key to LSD, okay? First thing, that's it. Number two is cannabis, all right? This is weed, right? So for weed or marijuana, what you need to worry about is conjunctival injection. This is just your bloodshot eyes that is present in patients that smoke marijuana. All right. So this is conjunctival injection. If you see that, they're talking about cannabis, right? That's pathognomonic for cannabis, all right? At least for question stems. All right. It's been very helpful for me. You could also see increase in appetite. That's what they know. It's like munchies. And then you could have euphoria. All right. But those are your key things for cannabis. And once again, in the presentation of the patient in the question stem, they're going to say like it's a young kid who starts acting weird. He's acting different. He's going on walks and he comes back with like bloodshot eyes. Boom. It's cannabis usage. All right. MDMA or ecstasy isn't too high yield. What I would say, bruxism, which is grinding of teeth, could be caused. It can also lead to hyponatremia because patients with MDMA intoxication or patients that take ecstasy, they increase their fluid uptake. So they start to drink like a ton and it causes hyponatremia. All right. Once again, not too high yield. And lastly is PCP. What they want you to know for PCP is both the mechanism of action and what you should be expecting in intoxication. So first you have NMDA receptor antagonist. That is the mechanism of action for PCP. Okay. That's one key takeaway. Do not forget that PCP acts via antagonization of NMDA. Next, what you need to know is that the patient's probably going to present with severe violence and nystagmus. Nystagmus is the highest yield thing for PCP intoxication, okay? And so then that's your kind of end-all be-all. So I'm going to kind of recap this. I know this is a long video, but I just want to take one last summary for everything. Okay, 1, alcohol, barbs, and benzos. What you need to know is the GABA A receptor positive allosteric modulator. Alcohol, what you need to know is for withdrawal, you treat it with long-acting benzos, and the patient's going to be present in the hospital. On presentation, he's going to be normal, and then 3 to 5 days later, he's going to present with delirium tremens type issues. Okay, that's how you know it's alcohol withdrawal. Benzo withdrawal, it's going to be similar anxiety, tremors, insomnia, and sympathetic hyperactivity, and you're going to treat alcohol withdrawal with long-acting benzos. Okay, opioids, for opioids, it's the mu receptor activation. For intoxication, you're going to see depressed mental status, respiratory depression, constipation, and meiosis, which is the pupillary constriction. On withdrawal of opioids, you're going to have dilated pupils, diarrhea, yawning, rhinorrhea, lacrimation, and piloerection. Inhalants, for intoxication, you're going to see glue sniffer's rash around the nose or mouth with a rapid recovery. Stimulants, for intoxication, all stimulants in general, you're going to see mydriasis, so dilated pupils, tachycardia, hypertension, and diaphoresis. And on the other hand, for withdrawal of stimulants, overall, you're going to see kind of lethargy, depression, increased appetite, and sleep disturbances with vivid nightmares. Cocaine specifically for stimulants, what you need to know is the mechanism of action is going to block reuptake of dopamine and norepinephrine, specifically norepinephrine transporters is key. And on intoxication, you're going to see chest pain, seizures, mydriasis. It can cause stroke and MI. You can see perforated nasal septum. And what you want to know is you're going to treat them with benzos. You have to avoid beta blockers. On withdrawal, you're going to see depression, acute depression. They're going to have vivid dreams, fatigue, hypersomnia, which is just hunger, or hypersomnia, and then hunger. Lastly is your hallucinogens. That's going to be LSD, is visual or auditory hallucinations on intoxication. Cannabis, the key takeaway is conjunctival injection, bloodshot eyes. Ecstasy or MDMA, not too much, pretty low yield, but I mean, think of like hyponatremia due to increased fluid uptake and bruxism, which is grinding of teeth, but not high yield. And then PCP, MOA, you have to know is NMDA receptor antagonist, and then they're going to be violent and have nystagmus. Nystagmus is key to intoxication with PCP.